Okay, so continuing on, we talked about the upper airways. Now we're going to move into the lower airways and the structures that you guys are going to be responsible for knowing. So for this diagram, this is moving down, if you can kind of imagine moving down into the lungs more. So you guys are aware of the trachea. This again is the carina, and the carina is just the landmark where the right and left main stem bronchus divide. So then you divide to your right lung and your left lung. And what I want you guys to know or have memorized is you go from your trachea to your main stem or main bronchus, either would be fine. And then you're going to go to lobar bronchus, and then you're going to go to segmental bronchus. So your trachea is your main airway. It's going to come down at your carina. It's going to divide into your main stem bronchus, right and left. And then the next biggest airway after that is going to be your lobar bronchus, which is just going to be the airways that go to the different lobes of the lungs. So your upper, middle, lower lobe on the right and your upper and lower lobe on the left. And then you have your segmental bronchus. And you guys are going to learn those 18 segments of the lungs, and each one has their own individual bronchus that feeds it. So knowing kind of that airway histology moving from trachea to main stem bronchus to lobar bronchus to segmental bronchus. This is just another diagram kind of showing a similar thing. This shows you where that cricoid cartilage is again. Again, very similar to your Adam's apple or where your Adam's apple would be located. We care about the cricoid cartilage because generally speaking, if we're assisting with an intubation, they will ask for cricoid pressure. And they do that to just kind of line that airway up and make it easier to get that breathing tube in. This is your trachea, and then this shows the carina again, your right main stem bronchus, your left bronchus, and it kind of shows you how this splits off. Another diagram showing the same things. Again, guys, I'm going to have a separate PowerPoint under a review tab that will show you the diagrams that you are responsible for knowing for the exam. If it's not in the review PowerPoint that says diagrams to know for exam 1, you don't have to know it. I just sometimes like to use more than one diagram to illustrate the structures so that you guys have more than one perspective. So again, kind of looking here, you have your cricoid cartilage, you're coming down through your trachea. This is your carina, your right main stem bronchus, your left main stem bronchus, and you can see how as it goes to your lobar and segmental bronchus, how they start to really branch off and get smaller and smaller and feeding smaller parts of the lungs. You can see your horizontal fissure, your oblique fissures, so lots of duplicate structures here that you guys have seen in other diagrams. The other thing I want to really point out to you is that your right main stem bronchus has a much steeper or a much more acute angle than your left. If you notice, it almost kind of goes straight down, whereas the left, it almost tees off a little bit more. So you have a 25-degree angle versus a 45-degree angle. You don't need to know the actual number of the angles, but just kind of having this visual of how it goes almost straight down. And the reason that's important is if somebody chokes or aspirates food or an object, which can happen a lot with little kids if they aspirate a small toy or a marble or something like that, more than likely it's going to go into the right main stem bronchus because of this kind of acute angle, making it almost a straight line from the trachea. The other reason that we like to know about that angle is when you are putting a breathing tube in, if you put it in too deep, past the carina in a position that you don't normally want it, if you put the tube in too deep, it will go into the right main stem. And when that happens, if you are not listening to breath sounds and taking an x-ray and catching that that tube is in too deep, you'll only be ventilating the right lung because it'll have traveled into the right main stem bronchus and not be ventilating the left lung. So that is why we care about the angles of the main stem bronchus. So just know that that right is at a more acute angle or a more steep angle, making it a more straight line from the trachea, which means things are just more than likely going to go to the right side, to the right lung, if you aspirate or if a breathing tube is too deep. This shows it again. X-rays are ones that are kind of harder to see it, so they have this kind of overlay on there to show you. Again, you can see the steepness of that angle and just how it would make sense that things are more likely to go into the right lung. This is a video you guys can watch on your own. You definitely don't have to watch the whole thing. I think it's like 10 minutes long. I just think it's helpful to watch the first couple minutes. It's a video of a bronchoscopy, which is where they take a camera on the end of kind of a long, narrow, flexible tube that they're able to control, and they travel in through the mouth, down through the trachea, and they can travel through your main stem bronchus, into your lobar bronchus, then into your segmental bronchus, and actually into the different segments of your lungs. And they do this for a variety of reasons. They can do this to get samples if they're concerned about lesions or possible cancerous areas of the lung. They can do this if you have what's known as mucus plugging, which is where secretions can get dried and actually block off parts of the airways and collapse parts of the lungs, and they can actually remove those blockages. They can do it to clear excess secretions. Cystic fibrosis patients that have a lot of retained secretions and issues with mucus clearance will kind of go in prophylactically or regularly to get their lungs cleaned out via bronchoscopy. So this is just a video to kind of show you those different pathways and how that anatomy looks in real life. In clinical, you guys often get a chance to go see one of these happening. The lecture questions at the end are pretty short for this one. This is an example of where I say define. So define aspiration. And in this one, it's not as important, but the thing I really want to caution you guys against doing is Googling aspiration or looking up aspiration in Egan and then just writing the verbatim definition. Obviously, you can use those as resources for sure. I don't want to see you copy and pasting definitions that you find, and I don't want you guys to use verbiage that you don't know. Now, for this one, the definition could be essentially how you would write it in your own words, so that might not be really applicable. But for some, the definitions are very, very complex and not wording that you would use as a student. So I just really want to challenge you, if I'm saying to define, describe, explain, really do that from your own perspective and how you understand a concept, because it will help me to see if you do actually understand it. And if you don't, I can help to clarify that before you're taking an exam where it really matters. And it also just, I think, really helps lock in a concept into your brain versus copying and pasting, which is plagiarism as well and not something that we want to be doing. But also, if you're using technical text and not trying to put it into your own perspective, I just don't know if it ever really lands the way that you want it to land. So just be aware of that as you move through these different questions and these assignments.